Hi, good people. I hope you're well. Today, let's look at a lecture on auscultation of lung and the heart sounds. So it's always a question that most of you guys were asking, and it's also a skill that we ought always to have, because you'll always see around hospitals people carrying stethoscope, but some of them they might not know how to use it. And why are they carrying it? Probably just carrying for aesthetic purposes and other things, but they are mainly used for the aspect of for we to do the auscultation, and you are focusing on the heart and the lungs, but we can also do other areas like the bowels and other places while we are doing the auscultation. But our lecture today, we are just focusing on the lungs and the heart sounds. So just for as a sort of introduction, you need to know that auscultation, why are we doing auscultation? It's now the act of listening to sounds. And these sounds are always made by, we talk of the internal organs and also vessels in the human body. So with our internal organs like the heart, the lungs, the liver, and also we have vessels, the blood vessels. So all these will always cause the sounds. Now, for we to listen to the sounds, we have to do auscultation as also part of a way that we can gather our evidence, so we can gather our information. It's mainly we can also do through auscultation. So don't forget that auscultation is an act of listening to sounds that are made by internal organs and vessels of the human body. So how do we do this auscultation? We mainly do using a device that we term is as a stethoscope. Apparently, throughout the lecture, you'll have a look at it. Don't have a physical one currently, I would have shown you. So this technique is always used to examine respiratory system, and for respiratory system, we are mainly focusing on the breath sounds. Then cardiovascular system, where we are looking at heart sounds and also vascular bruits, which might be there. And for GI system, we mainly check for bowel sounds, where we'll be able to say, are they hypoactive, are they hyperactive, are they normoactive? So through auscultation, it's when we are able to examine all these systems. We've talked of respiratory, cardiovascular, and gastrointestinal. But remember, for our lecture, we're just focusing on the two: respiratory, where we'll be looking at the breath sound, and cardiovascular, where we'll be looking at the heart sound and the vascular brutes. Don't forget about that. So, as our first organ, we'll mainly check the lungs. So, what is listed here or what is drawn here is now the structure of the lungs. So, you need to know we always have the right lobe and the left lobe. So, for the right lobe, for the right side, we talk of the right side and the left side. So, the right side has three main lobes. So, with the superior lobe, with the middle lobe, and with the inferior lobe, which are always separated by, we talk of the fissure, like the horizontal fissure separates the superior from the middle lobe, while the oblique fissure separates the middle lobe from the inferior lobe. So this is part of the right part of the lungs. What about the left? The left part is always separated by, we talk of the oblique fissure, which separates the superior and the inferior. So for the left part of the lung, we don't have the middle lobe. Don't forget about that. That's about the anatomy of the lung, how the lung is. It's made up of the different lobes separated by fissures. We talk of the horizontal and the oblique. Then next, now how can we now do the auscultation of our lungs? So from the diagram that we have been given, we have the front part and the back part on how we do. So the auscultation point and also the location. So if you want to do the auscultation of the lungs and you want to do it bilaterally, we start with 2 centimeters superior to the medial third quarter of the clavicle. So this is our clavicle. So if we listen at this point, we are now listening to the apex of the lungs. So we have to do also bilaterally, this side and the other side. Then next, if we want to do, we want to auscultate the superior lobes the superior lobes of the lungs, but here we are just looking at the anterior part. So we mainly do the second intercostal space, mid-clavicular line. So we've talked of this as our clavicle bones. So we do mid-clavicular, then second intercostal space. So is at this point. So at this point, we are listening to the superior lobes, but anteriorly. Don't forget about the superior lobes, these ones, the ones that we've just listed under the anatomy of the lungs. Then 3 with the superior lobes posteriorly. So we are listening behind. So we listen between C3 and T3. So we come here, these are our C3 from C3, from C7, to C3. So from here to here. At this point, we are listening to the middle lobe right anteriorly. That's another point that we can listen. Then we have the inferior lobe bilaterally inferior. So we listen at the 6th intercostal space mid-axillary line. So we've shifted from mid-clavicular. Now we are under mid-axillary. At this point, we are listening to the inferior lobes. Then we do bilaterally this side and the other side. Then the inferior lobes posteriorly, that is from behind. Now we listen between T3 to T10. From T3 to T10. At this point, we'll be listening at the inferior lobes. So just remember, for the apex, 2 centimeters superior to the middle third of the clavicle, superior. That's where we listen for the apex of the lungs. Then the superior lobe, second intercostal space mid-clavicular. Second intercostal space, you just count 1, 2, then it's mid-clavicular. Then for the superior lobes, posterior, it's behind, between C7 to T3. Then the middle lobe anteriorly, we do 4th intercostal space. So ideally if we talk the aspect of anteriorly, we do above the clavicle, then we go 2nd intercostal space, then we go 4th intercostal space, then we go 6th intercostal space mid-axillary. Don't forget about that. That's about the auscultation points. Now, how can we identify the intercostal space? We've just been talking about the intercostal space. So we mainly use with something known as angle of Lewis. So if you try check from this angle or from this diagram, angle of Lewis is located at this point. So for you to find or identify the intercostal space, now from this angle of Lewis, now you move your finger to the right and you'll feel the gap between the ribs. So if this is our angle of Lewis, it's at this point. Now we move 2 centimeters. Then when we, at the point that we feel a gap between the ribs, that's now the 2nd intercostal space. So we just move angle of Lewis, then we move 2 centimeters. So at this point where we are feeling a gap between the ribs, that becomes our 2nd intercostal space. So we continue on counting to 4th up to 6th. That is part of identification of the intercostal space. Don't forget about that. Now, how to auscultate. So we just started with an anatomy. Then we've looked at the sites or the auscultation points. Then we've looked at how can we identify these intercostal spaces that we are talking of. And now how do we auscultate? We've known about the anatomy. We've known on how to identify the intercostal space. We've known on how to identify the points. Now, how can we do the auscultation? So you need to know that while we are doing the auscultation, we need to listen to both anterior and the posterior sides of the chest. Both anterior and the posterior sides. Then we are doing laterally. Then you need to start at the top and work your way to the bottom of the chest while comparing sides. That's why we're talking of the aspect of bilaterally. We are comparing sides. Then we start from the top, the apex, as we go down to the lower lobes of the lungs. So while you are listening, you need to note the following: full inspiration and the expiration cycle. Then the inspiration and the expiration. So while the patient inspires or the patient expires, we need to check for the sound's pitch. We are checking for the pitch, the quality, the duration, and if it's normal sounding. Then is there any weird or any other thing that can be heard along with the inspiration or expiration? That's what we mainly check. So during we do the full inspiration and the expiration cycle, don't forget about that. Someone will try to trick you about that thing. So up to this point, if there's any other question, you can post it down. Can we just take a break? I see we've covered 10 minutes, then we continue. You can sip some water. Thank you. We are back. I hope you are well. So we were looking on how to auscultate, of which we are at par with that. So you need to know, you need to have the patient sitting up and with the arms resting on the lap while you are listening to the posterior sides of the chest. Okay, then that's mainly how we do. Then you need to have the patient be able to breathe in and out through the mouth slowly while you are listening. Then you need to allow the patient to set the pace so as to prevent hyperventilating, especially patients with breathing disorders like COPD. So while they are breathing in and out, allow them to set their pace. So don't tell them breathe this way. At some point, they might start hyperventilating, and we know also the hyperventilation is not a good thing. It might cause more other things. We can talk of issues like respiratory, it's as alkalosis. So you need to allow the patient to set the pace so as to prevent the issue of hyperventilating. So that's how we do the points, the way we just talked. We start from the apex, then we move to the second intercostal space, then we do the fourth intercostal space, then we do mid-axillary sixth, and we talked of the points at this point where we are auscultating. Then the posterior, that's how we do. We start above the scapula. Don't listen over the scapula. It's always above the scapula. Then we move down. We move down as we are assessing the breath sounds and also detecting anything that is not normal. So what are the normal breath sounds as we are doing all this? So we have the bronchial, with bronchovesicular, with vesicular, and with the tracheal. So these are always the normal breath sounds. Whenever you are asked in your exams, the normal breath sounds, we talk of bronchial, bronchovesicular, we talk of vesicular, and also tracheal. So they are 4 in number. And this diagram tries to, or this table tries to show us on how we can differentiate between the 4 breath sounds. So with the bronchial, bronchovesicular, the vesicular, tracheal, and others. So probably I can just pause for some seconds so that you might digest all this, and if you can take a screenshot, the better. So let me just pause for some few seconds, then we continue. Okay, we can now continue. I hope you took a screenshot or you recorded the information. So the table was just telling us how we do the point where we ought to listen to this breath sound. Next reads about adventitious sounds. So these are added sounds. They are not part of the normal breath sounds of which we've talked. We've said there are 4. We've said there are 4 or 5. Can do 1, 2, 3, 4, not 5, therefore. So one, we talk of crackles, and with pleural friction rub, with high pitched wheezing, with stridor. So you need to know for adventitious sounds, we've categorized them into 2, with discontinuing and with continuous lung sounds. So when you talk about discontinuing, these are always extra sounds. They are heard less than 0.2 seconds during a full respiratory cycle, so they are not continuing. We talk about the crackles, and also we talk about the frictional rub. So when you talk about crackles, they're always also known as the Rales. Rales, it's over here. So auscultated during inspiration, and they can extending to expiration as well. So what are the defining characteristics? They are always low pitched, wet, bubbling sounds, and may be heard in patients with issues with fluid overload and among other things. So with fluid overload and also pneumonia and other things, that's about cause crackles. What about friction rub? Friction rub, they're always auscultated during inspiration and expiratory. Then they're always low pitched stroke hushed grunting sounds. Then patient may have pain when breathing in and out due to inflammation of the pleural layers. Okay, that's about pleural friction rub. Don't forget about that. They're always two under discontinuing lung sounds, and they always had less than 2 seconds during a full respiratory cycle. What about continuous lung sounds? How will you differentiate between the other discontinuing? So for continuous lung sounds, they are always extra sounds, and they always had more than 2 seconds during a full respiratory cycle. So we talk of high pitched polyphonic wheezes and the low pitched monomorphic wheeze, not forgetting about stridor. So something about stridor, they're always high pitched and they are whistling or even grasping sounds with harsh sound quality. So stridor may be seen in children with conditions such as croup or even epiglottitis, or anyone with airway obstruction. Don't forget about that. What about wheezing? For the high pitched, they're also known as sibilant wheeze. So they're always mainly auscultated in the inspiration, but may also be present in inspiration there, but mainly they're always in the expiratory phase. Then these sounds are always high pitched and they are musical. Okay, so and they always had in patients with asthma. What about the low pitched monophonic wheezes? They're always known as wheeze or even Rhonchi. Another name is always Rhonchi. They're always low pitched monophonic wheezes. So these sounds, you need to know, they're always low pitched and they are heard in patients with COPD and also pneumonia and other conditions. That's about the monophonic wheezes. Don't forget about that. So we are done with the breath sounds. So the next thing that we are going to look at is we are looking at the heart sounds. So for the heart sounds, you need to know that they are mainly caused by closure of the heart valves. So from the anatomy that probably you've encountered, you'll know that for the heart to pump the blood well, it has to always open and close its valves. So as it opens and closes the valves, there are sounds that are always produced. So the first sounds that you hear is always S1, and this S1 you need to know that is always caused by closure of the AV valves, also known as the atrioventricular valves, and tricuspid and the mitral valves. So for S1 it always sounds like lab. Then the second sounds that you will hear, it's always caused by closure of semilunar valves and the aortic, not forgetting the pulmonic valves. At this point, we term it as S2, and it always sounds as dub. So S1 is lab, then S2 is dub. Then we might have S3 and S4. And for S3, we talk of it's always associated with the blood flowing into the ventricles. What about S4? It's always associated with atrial contractions. So you need to know that for the 4 heart sounds, they can be recorded by we term it as phonocardiography, but normally only the first and the second sounds are audible through the stethoscope. That's about something about the heart sounds. So what are the points or the sites that we listen? So with a mnemonic, you can go with all patients take medicine. So we talk of the aortic valve. P, we talk of pulmonary valve. T, we talk of tricuspid valves. Then M, we talk of the mitral valves. So like for aortic valve is always found right of the sternal border in the second intercostal space. Let's try and see, it's over here. Then remember we talked of, for now we identify the intercostal space, don't forget about that. Then 2 with pulmonic, which is found left sternal border, second intercostal space. So it's the opposite of aortic valve, the point that we get. So the other side, that's where we get the pulmonic valve. You can check here. Then the third one with the Ribs point. So it's always found left of the sternal border. Then we move third intercostal space. So from the second intercostal space, left sternal border, where we found the pulmonic valve, when we move one step down, we found the Ribs point. Then next with the tricuspid, which is found left of the sternal border in the fourth intercostal space. That's about the tricuspid. Then finally with the mitral, which is found mid-clavicular, fifth intercostal space. And at this point is also termed as the point of maximum impulse. You'll always hear people talk of PMI, that is point of maximum impulse. It is the mitral valve, fifth intercostal space, mid-clavicular. Don't forget about that. What are the basis of the other sounds, S3 and S4? So you need to know for S3 and S4, they always had based at the apex of the heart with the bell of the stethoscope while the patient is on the left side. Okay, so like for S3, we hear it after S2 and it will sound like lab, dab, ta. So that it's always S3. Then what causes? It's always caused by vibration of the ventricular filling from a resistant ventricle due to volume fluid overload or even issues with heart failure. So if you're having volume overload or we're having issues with heart failure, this means we'll be having a resistant in during the ventricular filling. So it will always cause S3. Then S4 is always had before S1. So the sound can be like ta, lab, dab. So it starts before S1. So what are the causes? It's caused by ventricular resistance from an atrial kick during presystole. So we talk of issues with hypertrophic left ventricle. That's about S3 and S4. So what are the two basic types of valvular disease? Remember we talked of while we were auscultating, we listened to the heart sounds, not forgetting about issues with valvular disease. So one, like for valvular diseases, we talk of valvular insufficiency, where we refer it more as incompetence. Then with valvular stenosis, don't forget about these terms. Like for valvular stenosis, it means the valve starts to narrow. But valvular incompetence, it means the valve is unable to close fully. So we're having issues with regurgitation. That's why we talk of valvular incompetence. So up to this point, we've covered all about the lung sounds and the heart sounds, the points where we listen, the points where we auscultate. If there's any other question, you can just post it down. Thank you for listening. For those that are new to the channel, we kindly urge you guys to give us a subscription, like, and share with these other people. Up to that point, we are done for the day. Thank you for listening. Have a good day. Bye.